Today my talk is on is luteal phase support different in FET cycles. I have no conflict of interest to record. Now, what we have noticed over the years is that the frozen-thawed embryo replacement is coming up in a bigger way compared to fresh cycle replacement of embryos, and the multiple pregnancy rate is coming down. There is definite advantage of using freeze-all cycles, and therefore we are discussing today the freeze-all in the masterclass, and I will be speaking today on the luteal support in freeze-all cycles. We know that more than 5 million babies have been delivered following assisted conception, and we also know that we need a lot of ovarian stimulation, which is meticulous, and this is also accompanied with luteal phase support in order to get great success. It is critical to use the progesterone with adequate clinical efficacy and tolerability. Otherwise, the patient will not use the drug, and we need to give her the right one which will help her to get success. Both fresh and frozen embryo transfer cycles are physiologically different, and hence luteal phase support should be modified accordingly. So the areas of discussion today will be the physiology of the corpus luteum and luteal phase, the need to support the luteal phase in assisted reproduction, the corpus luteum and the luteal phase, the difference in luteal support in fresh versus frozen embryo transfer cycles, and evidence-based recommendations. So if you look at the luteal progesterone synthesis, there are 3 critical endocrine events which happen. One is that there is an LH surge for follicular rupture, and secondly, it helps to luteinize the theca and granulosa cells, which then help in the progesterone secretion. The LH pulses increase in frequency and amplitude during the luteal phase, and this helps to assist the development and function of the corpus luteum. The HCG secretion, which occurs by the embryo's trophoblast, comes into circulation after implantation, and that sustains the corpus luteum function in early pregnancy. We know that the corpus luteum in a cycle which is non-fertile undergoes regression, usually within 12 to 14 days after it is formed. And this regression is both functional and structural. Functional because it stops progesterone secretion, and structural because it just disappears. There is apoptosis, and that causes a diminishing progesterone secretion, and hence there is the period comes on, and that is not a fertile cycle. And sometimes the mechanisms which actually cause this apoptosis, which are still unclear, they are unscheduled activation of these mechanisms occurs, and that could lead to a luteal phase defect, which then causes infertility. And we know that the corpus luteum gets rescued in the fertile cycle. And this happens because the HCG, which comes from the trophoblast of the implanted embryo, that appears in circulation on day 8 after ovulation, and it rescues the corpus luteum. And how does it rescue the corpus luteum? By stimulating the LH receptors on the corpus luteum and increasing the progesterone levels. It also expands the vascular network of granulosa and theca cells. It also releases an it helps the angiogenic factor, that is VEGF, which is existing in the ovarian tissue. It enables it to respond to the HCG, and it also has the ability to prevent apoptosis of corpus luteum by lowering the pro-apoptic protein BAX, which is present in the corpus luteum. So these are the different ways HCG rescues the corpus luteum and allows it to go further and not regress, and help in the support of the pregnancy until the placenta is formed, and that is when the luteoplacental shift takes place and the placenta takes over the function at about 9 weeks of pregnancy. As the corpus luteum gets rescued in a fertile cycle, it enlarges in amount, which can be very well seen on ultrasound and Doppler. The maximum venous velocity increases with the progesterone levels. The corpus luteum then remains indispensable up to the age of 49 days, because when corpus luteum is removed before 49 days, you'll find that the pregnancy gets terminated. And once this luteoplacental shift occurs with the development of the placenta, and that is when the corpus luteum can become dispensable. But today we have no tools to diagnose the luteal phase defect, nor the implantation defects, and nor the endocrinology of early pregnancy loss. There's a lot of ongoing research, but there's no specific lab value which we can do, by which we will know that there is an issue. So we have the natural cycle where you have a single follicle where the estrogen level rises to 200 picograms per milliliter, and the controlled stimulation cycles where you have multiple follicles with an estrogen level going up to 1500 to 3000 picograms per milliliter. And in a patient who's undergone an ovum pickup cycle, in those patients, you'll find that because of the excessive estrogen levels, it suppresses the levels of FSH and LH2, and therefore that reduces the stimulation to the corpus luteum, leading to a drop in the progesterone. Then if we always tend to use the agonist or the antagonist, which also reduces LH, and then you have the aspiration of the granulosa cells during the ovum pickup, which again reduces the amount of progesterone which could be secreted by the corpus luteum because there are less number of granulosa cells present. And hence, because of all these reasons, there's a relative luteal deficiency which occurs and leading to a progesterone insufficiency. Now, the luteal phase in the natural cycle versus a COS cycle, you'll find that there is a difference. The mid-luteal phase is the most critical as implantation occurs during this phase. That is the time when the embryo implants. And 8% of even natural cycles, when there's no excessive stimulation, also have luteal insufficiency. So it has been seen that in the natural cycle, day 7 after ovulation, the mid-luteal progesterone determined for a successful implantation is about 10 nanograms per milliliter, whilst with a controlled ovarian stimulation cycle, at the same time, you should be having approximately 30 to 50 nanograms per milliliter. So the luteal support in the frozen embryo transfer cycles will vary accordingly. And we know that we get the best outcomes when there's a good endometrial embryonic synchronicity, there's optimal frozen embryo transfer timing. We must have the best preparation of the endometrium, which has all been discussed in this masterclass by other speakers. And I'm going to be speaking on the optimal luteal phase support. The luteal phase support depends on whether it's a natural cycle, which may be a natural cycle, or it may be a modified natural cycle. At the same time, we can have programmed cycles, that is the artificial cycles, in which the corpus luteum is absent. In the natural and modified natural cycles, the corpus luteum remains present, which releases the endogenous progesterone. And even other molecules like VEGF and relaxin, which are necessary as we go along, I'll discuss that, and those are also present. So we must remember that there is endogenous progesterone present in the natural and modified natural cycles, whilst in the programmed or artificial cycles, there is no corpus luteum. So the timing of the embryo transfer should be based in a natural cycle, should obviously be based on a natural LH surge. And therefore, we can offer it only to women who have ovulation, with the main rationale being that you need to synchronize the endometrium and the embryo, and you must do the transfer during the physiological implantation window. This spontaneous LH surge, as we all know, has to be very closely monitored with LH and progesterone levels. And unless one does that, you'll never know which day really to transfer the embryo. The day 3 or 5 of embryo transfer is done after we are doing a day 3 embryo. And on day 5 to 7, we would do the blastocyst transfer. This is after the LH surge. So we need to identify when the LH surge occurs. Now, the main difference is to trigger ovulation with a modified natural FET cycle compared to a completely natural FET cycle. The only difference is that you're going to trigger ovulation with HCG when you have the required parameters as shown over here. And the ET is done 5 days after trigger. There has been a little conflicting report results whether the HCG which we are giving for trigger, is it sufficient for helping with the luteal phase support, because HCG itself will release more progesterone from the corpus luteum. But there have been RCTs done of 18 studies with 3,333 women who failed to show no significant difference whether you give the injection HCG or no injection in the FET cycles. So in a FET cycle, we always worry that, where is the need to give this is the modified natural FET cycle where you're expecting ovulation to occur, you're giving the trigger, and you are at the same time deciding whether to give the progesterone support or not. But there's no significant difference whether you give it or you don't give it. So if you look at the natural cycle and the modified natural cycle FETs, you will find that you would give in a natural cycle on day 1, you would go with the natural, follicle growing, and when it reaches the dominant stage, you will look for the LH surge, and you'll monitor the endocrine monitoring once or twice daily with urinary and serum LH levels, and you do the ultrasound to confirm the presence of ovulation of corpus luteum and ovulation, and you will time the embryo transfer about day 6 or 7 post LH surge if you're doing a blastocyst transfer. And 11 days after the transfer, you will do the beta HCG. At the same time, with the modified natural cycle, you will allow the patient to go with a normal ovulation cycle, and you would give her a trigger when she reaches a dominant follicle of about 18 to 20 millimeters. And then you would again monitor the same way to look for ovulation and do the transfer accordingly on day 6 or 7 after the HCG trigger has been given. The luteal phase support and program cycles for FET, which are really not with any endogenous progesterone, you have to give extensive luteal support due to the absence of the corpus luteum. And because of that, we all know that patients who have gone through an artificial cycle, they tend to have a higher risk of hypertensive disorders of pregnancy. And this is because there's a diminished secretion of VEGF and relaxin, which actually help in implantation by improving the vascular compliance. But when there is no VEGF or relaxin, as it occurs with no corpus luteum, there is a reduction in the compliance, and therefore leading to a higher chance of having pregnancy-induced hypertension. With the programmed FET cycles, you're mimicking the menstrual cycles by commencing estradiol and giving progesterone sequentially, just as happens in an actual menstrual cycle. And the advantage is that you can use it for women who have got anovulatory cycles, for those who cannot reach for close monitoring, because here you're not monitoring ovulation, which is spontaneous, but here you're actually monitoring only the endometrium to see whether the endometrium is growing well. And it provides flexibility both to the patients and to the clinic. Estrogen supplementation, as we all know, helps to develop the endometrium. It suppresses any endogenous follicle development, so it prevents the natural ovulation to occur. It upregulates the progesterone receptors, and in 8% of women, follicle suppression still is not achieved, and therefore in those patients, we tend to give we start with a higher dose of estrogen as compared to the other patients who we normally start with 2 milligrams 3 times a day of estradiol valeriate. And this can be extended up to 20 days in order to build the endometrium to the right phase, and then supplemented with progesterone to have the secretory changes. So this is how we would do it. We would start oral estrogen or transdermal estrogen on day 2 of the cycle, continue giving it for 7 to 8 days, call the patient in, do a scan, check whether she has grown well, and we wait for the typical triple line layer and with a good endometrial thickness. And once we have reached a thickness of more than 7 millimeters and a good triple line layer, which usually happens between day 10 to 13, then we start with the progesterone, and the embryo transfer is done on 5th or 6th day of the progesterone. And this estrogen progesterone is continued all the way when she's pregnant up to 10 weeks of gestation. If there are patients who have reason for us to start with either an agonist or an antagonist, then we would do that in patients who will require that therapy. So if we have to assess the luteal phase efficiency in FET cycles, do we need to do mid-luteal progesterone levels, or do we need to individualize a luteal support in FET? So there have been studies to assess this, and this study is put together in December 2020 based on the various studies which have already been reported. And most of them are retrospective studies, but this study in 2017 was a prospective cohort study with 244 oocyte donation cycles, and there were 800 milligram vaginal progesterone Different doses of progesterone or vagina have been used. So we use vaginal progesterone quite effectively in frozen embryo transfer cycles. And this date of progesterone measurement in all these studies have been done either 1 day before ET or ET plus 2-3 days, within 2 to 3 days. And what they all said was that live birth rates are better with higher progesterone, ongoing pregnancy rates are better with higher progesterone. Again, this says live birth rates are better, this one says the same, and this one says it's the same. So in short, we do definitely have evidence that by adding progesterone, with having good mid-luteal progesterone levels will give better pregnancy rates. So what is the kind of progesterone level we are looking at? And therefore, this study, which is a prospective observational study where euploid embryos, to make sure that the abortion is not because of abnormal embryos, were put in 547 cycles of 453 patients. And they were divided into 2 groups with a progesterone of either more than 10 nanogram or less than 10 nanogram per ml. And almost 98% of the patients had been put on subcutaneous progesterone starting from the day of embryo transfer. And here, what did they find? They found that very surprisingly, that those patients who had a progesterone level of more than 10 had slightly lower pregnancy rates compared to the ones who had a lower progesterone rate. And here the miscarriage rate was higher as compared to the progesterone, which is less than 10. So in short, the wider implications are that this probably is an opportunity window that if you find that the patient is having pregnancies but having miscarriages, then probably supplementing progesterone in FETs with P4 levels more, which are less than 10, we should add progesterone and restore them back to the more than 10 nanogram per ml, which was there prior to ET. So this is what could mean, though the levels give you the similar pregnancy rates, etc., but the miscarriage rates are definitely mixed up. Progesterone may be available in different methods, protocols available, either we use oral, we use vaginal, or we use intramuscular. Now here the table is comparing the intramuscular progesterone versus vaginal progesterone. And if you see this RCT, which is latest in 2018 with 670 cycles, where they use 50 milligram per day intramuscular progesterone versus vaginal tablet 200 milligram twice a day versus 50 milligram intramuscular progesterone plus vaginal tablet 200 mg twice a day. And here they found that the ongoing pregnancy rates are lower and miscarriages are higher on the vaginal only arm. So I'm sorry, this was really intramuscular progesterone versus the vaginal progesterone in one arm, and the other arm where both were used together. So in short, they found that the ongoing pregnancy rates are lower and the miscarriages are higher in only vaginal arm. So it's a good idea to combine the two, and that really helps. So then we have the oral progesterone, which comes as a natural progesterone capsule or a synthetic progesterone, which is dydrogesterone. And oral progesterone somehow, because of its hepatic first pass effect, has a limited efficiency, and therefore in these patients we are not recommending it for luteal phase support. What we are using is synthetic progesterone, which has a 3 times higher bioavailability versus natural progesterone, and hence it's more potent. And it has no effect on any other receptors like estrogen, androgen, glucocorticoid, but has a mild anti-mineralocorticoid effect. Now, this study, which has been, these trials of Lotus trials, has been done to assess the efficacy of oral dydrogesterone, and they've done the phase 3 RCTs, where they have started the support on day of ovum pickup and done till 12 weeks of gestation. This study has been done on fresh embryo transfer cycles. I could not come across any study which is done on frozen embryo, in frozen embryo transfer cycles, but in short, what it says is that it's equally acceptable to use either vaginal progesterone, 90 milligrams per day, either in the tablet form 200 TDS or in the gel form 90 mg once a day, comparing it to 30 milligram 3 times a day of progesterone oral. And this is something could be an alternative to those patients who are not willing or they are allergic to using vaginal progesterone. Now here is a new study, which is a GnRH agonist administered in the luteal phase in artificial cycles, and they wanted to study the effect of a single dose of GnRH agonist on artificial cycle FET. And this is a prospective randomized controlled trial of 1,052 women, and there were availability of good quality embryos of day 3 were required after thawing, and only those patients were included in the study. Now here, they were divided into 2 groups. The first group had 434 patients where either 0.1 milligram triptorelin acetate was used 3 days after embryo transfer, and 434 patients where no agonist was used. And the results were that the similar outcome in both the groups, but there were no significant beneficial effects seen on overall pregnancies. But there was one group of women, that is older women, which is between 35 to 37 years, where they found that there was a better implantation rate. So here you have the results, everything almost the same, but there is a significant rise in the implantation rate in this group of patients. Currently, there's an E-Freeze trial, which is an ongoing trial, which is a multicenter randomized controlled trial comparing fresh versus FET to determine if a policy of FET results in a higher healthy baby rate. Now, this is something which is ongoing and it is not yet available to us as an answer. So therefore, we'll wait for the result to be announced, after which we will know whether Freeze-on is really helping us with a healthy baby. So in concluding, I would like to say that luteal phase support may differ depending on the endometrial preparation for FET cycles, which is level 1A evidence. No significant difference is found in terms of clinical efficacy between natural, modified natural, or programmed endometrial preparation protocols. In natural or modified natural FET cycles, additional luteal phase support does not improve outcomes based on the limited data we have today. And due to absence of corpus luteum in programmed FET cycles, luteal phase support must definitely be provided. And there is no consensus today regarding the type and duration of optimal progesterone support for programmed FET cycles. And based on studies achieving a minimum threshold of serum progesterone levels more than 9 to 10 nanograms during the mid-luteal phase in programmed FET cycles seems to improve clinical outcomes, and therefore this is what we must aim for. For luteal support in programmed FET cycles, 180 milligram per day vaginal progesterone gel and 50 to 100 milligram per day intramuscular progesterone provide similar efficacy levels, and there is no sufficient data on oral dihydrogesterone administration for the luteal support in FET cycles. I thank you all for your kind attention.